Good afternoon. I thank JVK sir as well as the organizing team for providing wonderful opportunity. I thank my chair for wonderful prologue about me, and my topic is moving forward. There is a gaining a wider outlook of diabetes management with the generation 2.0 basal insulins. So what is the difference between, I thank the previous speaker for leading a good platform as well as also having insight about the hypoglycemias and all. So what is the difference between 2.0 basal insulin and the old Lantus Euglagen 100 insulin is Tamil movie Endran and 2.0. In Endran, the Chitti has a good role. First part will be hero, and second part is like a villain. Same thing, Endran 2.0, it becomes a superhero doing unimaginable things. Same thing is applicable for Euglagen 100 and Euglagen 300. So in nutshell, I make it very simple. My presentation will be simple as decorated by chair. And apart from the triad, that is the triad of glycemic control, fasting, post-meal HbA1c, we have to have much knowledge about glycemic variability, where it is measured in terms of time in range. So apart from HbA1c, because many people have good HbA1c control, in spite of having good HbA1c controls, are prone to develop micro and macrovascular complications. The undetermined factor that we are not being addressed is time in range, which tells about the mirror about the glycemic variability. How Euglagen 300 is going to do justice in terms of addressing this glycemic variability and improving the compliance of therapy, and what is the role of the molecule to the existing ultra long acting insulin Degludec 100. And beyond HbA1c, you must know what is time in range, because international guidelines supports recommend time in range because of usage of continuous glucose monitoring. And it is a major challenge because day-to-day variability, inter-day, intra-day variability is also being taken into consideration in glycemic variability. And people having high glycemic variations, making a peak and trough, are at risk of developing diabetes-related complication. You are not seeing only the peak, the trough, that hypoglycemia also can impart and a severe risk for the individual, which is not been explored by HbA1c. HbA1c will tell which sugar is under control or not control, but it will not have any idea or outlook on how hypoglycemia happens for the individual for that matters. And thanks to the technology, that because of continuous glucose monitoring, we can have set a goal for the individuals. Any patients comes to our clinic, we can set a goal. The physician can set a goal for the individuals, how much amount of sugar should be there for you. Patient 50 years, not having any comorbidities, you can set a goal of 70 to 180. Patients of 90 years, comorbid illness, morbid CKD, heart risk of hypoglycemia, you can even fringe benefit of giving 100 or 180 for that matter for in diabetes control. So we need the plasma, the plasma glucose in the streamline shifting from 70 to 180. The most of the day, at least 70% of the day should be spent in the set target goal of 70 to 180. So type 1 DM, they have given a goal, that is ATD, Advanced Technologies and Treatment Advice, has given a goal how to integrate TIR. So type 1 and type 2 DM are not at risk of hypoglycemia. You can keep a goal of 70 to 180. More than 70% of the day has to be spent in this level. High risk people or elderly people at risk of hypoglycemia, you can have some sort of bridge benefit. 50% of the day should be spent in 70 to 80% and 50%, and none of the goal should crosses more than 250. It's even applicable for a pregnant individuals. This is a concept behind the TIR. That is, more than 70% of the day, the patient has to sail in a good glycemia of a set target of 70 to 180. And if you don't put the patient in this target zone, the patient at risk of both retinopathy, at risk of nephropathy and microalbuminuria, and not only microvascularization, they are at risk of developing any CV mortality and all-cause mortality. As like HbA1c, 1% of HbA1c escalation translates in terms of hazards in terms of macroalbuminuria. Same thing applicable for TR. If you not optimally control TIR, the patient is at risk of developing micro and macrovascular complications. And this was proposed by Mohan et al. How you can use this in your day-to-day practice, especially in type 1, you can assess insulin requirement. You can which insulin you can increase, whether short-acting insulin is required, or the patient is developing hypoglycemia, which may be the reason behind, which is a basal insulin or short-acting insulin. Same thing can also applicable for type 2 in day-to-day management, monitoring the diet of the individual, monitoring the OHS of the individuals, monitoring the impact of the exercise on the glycemic control. And next is, well, let us compare Euglagen 300 and Euglagen 100. Is there any benefit in terms of HbA1c reduction? Is there any benefits? Because I wanted to move from Euglagen to Euglagen 300, what benefit I'm going to give for my patients? So if you analyze, there was a study conducted in 16 weeks randomized cross-control study, where initially 8 weeks the patient on Euglagen 100 shifted to Euglagen 300 and vice versa. And the enroll, they done when GV metrics was analyzed. And the nutshell, the snapshot shows euglycin 300 improves the glycemic variability. You can see the markers. You can see the markers. There is a static line. The glycemic variations is not there even if you inject at the same point. The injection was given in the early morning. Even across the 24 hours, it is a static. There is no any peak or trough. As like euglycin 100, more than 24% smooth glucose profile with the less incidence of nocturnal hypoglycemia was there. And same thing they compared another trial, the flexibility of injections. So when you give euglycin 100 has to be given at same time. Suppose you want to give in the night by 10 o'clock, all the days has to be followed by 10 o'clock. But there is a flexibility dosage. What happens when you give shift 3 hours prior or 3 hours later to this? Suppose you are giving 9 o'clock, can you give the injection by 11 o'clock, or can we prepone the insulin by 7 o'clock? What happens for the individuals? But there was 6 months trial was clearly showed there is a marked, I think, even if shifting, it shows marked improvement. Even the flexible time adjustments of this euglycin 100 depicts same impact as that of a fixed dose drinks, and you can shift the insulin by giving euglycin 300 for the individuals. You can even the patients fails to take insulin at the stipulated period of time can postpone before or after 3 hours. Totally 6 hours level free interval is there for the individuals. And euglycin on impact of nocturnal glycemic variations, they compared with euglycin 100 and 300, they can share there is no much peak or trough when you give euglycin 100, especially in the early morning period. So nocturnal glycemic variation is very low if you shift euglycin 100 to euglycin 300. And what is the role in compared to the other second generation, especially IDUC? There are many data is there. I am not going to project all the data because font of time. I am going to put on Bailey and Lucid and Kawakushi's. This euglycin 300 the trials depicting the role of TIR. They compared with degludec 100 with euglycin, same dose, same point of time in 45 PSH people. They clearly check the flat profile of euglycin 300 compared to the degludec. That resulted in 20% within a day glycemic variabilities is there, and also intraday variations is very phenomenal in euglycin 300 compared to the degludec. And other demonstration, nearly you can see that euglycemic clump, the insulin peak. There is a peak of degludec in the plasma serum, but you can't see any much peak in euglycin 300 compared to the degludec. And the pump infusions also has clearly showed the infusion rate is very static. It speaks about the good quality market. It's a peakless insulin without any peak or trough when compared to the degludec with euglycin 300. So what is the data we have comparing euglycin 300 degludec in TIR? This was conducted by Kawasaki. It is a randomized double crossover study where 15 people on euglycin 300, 15 patients, they shifted back. Last 2 weeks were done CGMS. They showed there is no much difference in the HbA1c reduction, and the peak and trough is there is no much. But the thing what we have is the anytime hypoglycemia is very low in euglycin 300, and the nocturnal hypoglycemia or any form of severe hypoglycemia is there. Even though we have comparable TIR, the target below range is very negligible in euglycin 300 compared to the euglycin degludec 100. So the molecule speaks about that is a flat profile of the molecule compared to the degludec, and there is a less incidence of hypoglycemia, especially nocturnal hypoglycemia or any form of hypoglycemia, but had a good HbA1c control and addressing the glycemic variability. And it's a flash glucose monitoring trial where they want to know what is the role of level of euglycin 300 compared to the degludec. You can see the insulin spikes are there in the early morning if you give degludec, but the spikes are not there. That speaks about the quality of the molecule. The entry of the insulin in the plasma is being gated in such a way there is a flat profile. Especially in the nocturnal period, the insulin spikes in the plasma is very low. That may be reason for low incidence of nocturnal hypoglycemia with this molecule compared to the degludec. And one case study also same things. There are switches. People, one arm was standard euglycin 300, another as degludec. They clearly showed there is no much difference in TIR, target above range or below range between these molecules, but the few incidents of hypoglycemia risk is very low in euglycin 300 than compared to that of degludec 100. This Basal plus, what we want to add Basal therapy, insulin co-formulations twice a day. They compared euglycin 300 with 2 shots of glulysin and 2 shots of IDUC aspart combinations in the people, and the primary endpoint was target range, target below and target below less than 70, especially nocturnals. They clearly find out that there is a target range was superior in euglycin 300 glulysin. So Basal plus therapy also shows much more than that of a co-formulations. And hypoglycemia risk is very low. Especially we have to speak about the nocturnal hypoglycemia risk. So we can achieve targeted range without inducing any hypos, especially nocturnal hypoglycemias, when you give this euglogen 300 compared to the degludec for the matters. In range state, it was conducted in type 1 patients where after randomization of 4 weeks, one arm was given euglogen 300, another is degludec, and the primary endpoint and secondary endpoint was primary endpoint targeted range in a set rate of 70 to 180 at the week of 12, and secondary endpoint was glycemic variations. It speaks about the primary endpoint. There is no much non-inferiority of the euglogen 300 is proved with the degludec in terms of secondary endpoint in glycemic variabilities. So the molecule in primary endpoint in glycemic control is at par equal that of a degludec, and at par equal that of a glycemic variability in degludec when compared to the degludec, and the occurrence of hypoglycemia, especially nocturnal hypoglycemia, is very, very low in type 1. The carry-over message is the glycemic variability and suboptimal TAR, it has to be taken into consideration whenever we design our treatment. We have to give importance for the glycemic variability, and we have to make the people's glycemia to be in the time range as said by the physician for the individuals. And euglogen 100 is just the flexibility of dosage. You can give 3 hours prior or 3 hours post to the scheduled time. That it will not have any impact on the glycemic variations in terms of hypoglycemias. And numerous trials have clearly showed the TIR and the continuous glucose monitor is clearly enlightened the TIR of euglogen 300 compared to the euglogen 100 or degludec. And the one point which you have to take into consideration, euglogen 300 is associated with less incidence of nocturnal hypoglycemia compared to the euglogen 100 or degludec. Thank you for the patient listening. I think